Hello, everyone, and welcome to week 4, NUR 491, Effective Leadership and Management in Nursing. I am your professor, Dr. Marian Johnson, and welcome back. I hope everybody's having a great time. Excellent work that's being produced. Thank you for everybody that's been prompt. For those that need additional time, please let me know beforehand that you need additional time, as there's a process to accepting late work. So please be punctual and considerate for myself and your discussion members, your other students. So let's get started with week 4 with budgeting and managing fiscal resources. Budgeting is the process of planning and controlling future operations by comparing actual results with planned expectations. That comes out of Finkler and Kovner of 2007. A budget is a detailed plan that communicates these expectations and serves as the basis for comparing them to actual results. The budget shows how resources will be acquired and used over time, over some specific time interval. Its purpose is to allow management to project activities into the future so that the objectives of the organization are available at the appropriate time. Lastly, a budget helps management control the organization. Budgeting is performed by business, government, and individuals. In fact, nearly everyone budgets, even though he or she may not identify the process as such. Even if a budget exists only in an individual's mind, it's nonetheless a budget. Anyone who has planned to pay a particular bill at some time in the future, say 6 months, has a budget. Although it is very simple, that plan accomplishes the essential budget functions. One now knows how much of a resource money is needed and when in 6 months it is needed. Note that the when is just as important as the how much. The money has to be available at the right time. Demands for patient safety, reimbursement changes with healthcare reform, technological advances, and the changing roles of healthcare providers require that budgets be constructed as accurately as possible and variances be as low as possible. This is no small task. Attention to the budgeting process is the first step in understanding how to use your resources most effectively. The budgeting process. A budget is a quantitative statement, usually in monetary terms of the plans and expectations of a defined area over a specific period of time. Budgets provide a foundation for managing and evaluating financial performance. Budgets detail how resources, money, time, and people will be acquired and used to support planned services within the defined time period. The budget process also helps ensure that the resources needed to achieve these objectives are available at the appropriate time and the operations are carried out within the resources available. The budgeting process increases the awareness of costs and also helps employees understand the relationship among goals, expenses, and revenues. As a result, employees are committed to the goals and objectives of the organization, and various departments are available to coordinate activities and collaborate to achieve the organization's objectives. Budgets also help management control the resources expended through an organizational awareness of costs. Finally, budget performance provides management with feedback about resources management and the impact on the budget. Budgeting is a process of planning and controlling future operations by comparing actual results with planned expectations. Planning first involves reviewing established goals and objectives of both nursing and the organization. Goals and objectives help identify the organization's priorities and direct the organization's efforts. To plan, the organization must know the following: demographics of the population served, community influences and competitors, sources of revenue, especially with changes in reimbursement due to the enactment of healthcare reform, statistical data, including number of admissions or patient appointments, average daily census, average length of stay, patient acuity, projected occupancy or volume base for ambulatory or procedure-based units or home care visits, wage increase of marketed adjustments, price increases, including inflation rate for supplies and other costs, costs for new equipment or technologies, for example, wound vacs, sequential compression devices, monitoring equipment, staff mix, for example, RNs, LPNs, and UAP. Regulatory changes, for example, legislation mandating nurse-to-patient ratios, State Board of Health regulations for the budgetary period. Organizational changes, for example, decentralization of pharmacy or respiratory therapy services that result in salary and benefit dollars being charged in portion to the unit. Management normally uses the past as the common starting point for projecting the future. But in today's volatile payment environment, the past may be a poor predictor of the future. This is one of the major drawbacks of the budgeting process. In a rapidly changing industry, basing budgets on historical data often requires readjustments during the actual budget period. Controlling is the process of comparing actual results with the results projected in the budget. See the section on monitoring performance during the year later in the chapter. Two techniques for controlling budgetary performance are variance analysis and position control. By measuring the differences between the projected and the actual results, management is better able to make modifications and corrections. Therefore, controlling depends on planning. Approaches to budgeting. Budgets may be developed in various formats depending on how the organization is structured. They may be considered as cost centers. Managers are responsible for predicting, documenting, and managing the costs, staffing, supplies of the division. Revenue centers. Managers are responsible for generating revenues, previously by increasing patient volume, although healthcare reform may make the future of revenue-generating centers obsolete. Profit centers. Managers are responsible for generating revenues and managing costs so that the department shows a profit. Revenues exceed costs. Investment centers. Managers are responsible for generating revenues and managing costs and capital equipment, assets. Nursing units are typically considered to be cost centers, but they may also be viewed as revenue centers, profit centers, or investment centers. How the unit is considered is crucial in determining the manager's approach to budgeting. Also, some nursing managers are responsible for service lines, and their staff are from multiple disciplines and departments. Other nurse managers are responsible for a single unit, such as a telemetry unit or the staff in a multiple physician office. The organizations may choose various approaches or combinations of approaches for requesting departmental managers to prepare their budget requests. These approaches are incremental, line by line, zero-based, fixed, and variable. Incremental budget. With an incremental or line by line budget, the finance department distributes a budget worksheet listing all expense item or category on a separate expense line. The expense line is usually divided into salary and non-salary items. A budget worksheet is commonly used for mathematical calculations to be submitted for the next year. It may include several columns for the amount budgeted for the current year, the amount actually spent year to date, the projected total for the year based on the actual amount spent, increases and decreases in the expense amount for the new budget, and the request for the next year with an explanation attached. The base or starting point for calculating next year's budget request may be either the previous year's actual results or projected expenditures for the current year. For salary expenses, the adjustment may be the average salary increase projected for next year. For non-salary expenses, the finance department may provide an estimate of the average increase for supplies or opt to use a standard measure of cost increases, perhaps the consumer or medical price index projected for the next year. To complete budget worksheets accurately, managers must be familiar with expense account categories. What type of expenses, such as instruments and minor equipment, are included under each line item. In addition, the manager has to keep abreast of different factors that have affected the expenditure level for each expense during the current year. The projected impact of next year's activities will be translated into increases or decreases in expense levels of the nursing unit's expenditures for the coming year. The advantage of the line-by-line budget method is its simplicity of preparation. The disadvantage of this method is that it discourages cost efficiency. To avoid budget cuts for the next year, an astute manager learns to spend the entire budget amount established for the current year, because this amount becomes the base for the next year. Zero-based budget. The zero-based budget approach assumes the base for projecting next year's budget is zero. Managers are required to justify all activities and programs as if they were being initiated for the first time. Regardless of the level of expenditure in the previous years, every proposed expenditure for the new year must be justified under the current environment and its fit with the organization's objectives. The advantage of zero-based budgeting is that every expense is justified. The disadvantage that the process is time-consuming and may not be necessary. For that reason, organizations may not use this process every year. An adaptation of the zero-based budget is to start the budget with a lower base, for example, 80% of the current expenses. Managers then have to justify any budgetary expenses requested above the 80% base. Fixed or variable budgets. Budgets can also be categorized as fixed or variable. In a fixed budget, the budgeted amounts are set with regard to changes that may occur during the year, such as patient volume or program activities that have an impact on the cost assumptions originally used in the coming year. In contrast, variable budgets are developed with the understanding that adjustments to the budget may be made during the year based on changes in revenues, patient census, utilization of supplies, and other expenses. The operating budget. The operating budget, also known as the annual budget, is the organization's statement of expected revenues and expenses for the coming year. It coincides with the fiscal year of the organization. a specified 12-month period during which the operational and financial performance of the organization is measured. The fiscal year may correspond with the calendar year, January to December, or another time frame. Many organizations use July 1st to June 30th. The federal government begins its fiscal year on October 1st. The operating budget may be further broken down into smaller periods of 6 months or 4 quarters. Each quarter may be further separated into 3 one-month periods. The revenues and expenses are organized separately with a bottom line net profit or loss calculated. The revenue budget. The revenue budget represents the patient care income expected for the budget period. Most commonly, healthcare payers pay a predetermined rate based on discounts or allowances. In many cases, actual payments generated by a given service or procedure will not equal the charges that appear on the patient's bill. Instead, the healthcare provider will be reimbursed based on a variety of methods. These include reimbursement of a predetermined amount, such as fixed costs per case Medicare recipients. Negotiated rates, such as per diems, a specific reimbursement amount per patient per day. Negotiated discounts and capitation. One rate per member per month, regardless of the service provided. Revenue projections for the next year are based on the volume and mix of patients, rates, and discounts that will prevail during the budget year, the budget period. Projections are developed from historical volume data, impact of new or modified clinical programs, shifts from inpatient to outpatient procedures, and other influences. Today, however, these projections might not be viable, especially in the light of healthcare reform. With implementation of accountable care organizations and medical homes, Medicare reimbursement is expected to change from Burr House 2010. Instead of paying for inpatient services at a predetermined specific rate for each Medicare recipient based on the patient's diagnoses, DRGs, providers will be reimbursed for care of patient groups. Excuse me. The expense budget. Expense budget consists of salary and non-salary items. Expenses should reflect patient care objectives and activity parameters established in the nursing unit. The expense budget should be comprehensive and thorough. It should also take into consideration all available information regarding the next year's expectations. Described in the next section are several concepts and definitions related to the budgetary process in a healthcare setting. Cost centers. In healthcare organizations, nursing units are typically considered cost centers. A cost center is described as the smallest area of activity within an organization for which costs are accumulated. Cost centers may be revenue producing, such as laboratory and radiology, for non-revenue producing, such as environmental services and administration. Nursing managers are commonly given the responsibility for costs incurred by their department, but they have no revenue responsibility. Swig. Stay tuned to find out what I'm drinking. In contrast, if managers are responsible for controlling both costs and revenues, and if their financial performance is measured in terms of profit, the difference between revenues and expenses, then the manager is responsible for a profit center. Customarily, nursing is not directly reimbursed for its services. As stated previously, nursing costs today are included in the room charge, although that may change as methods to match nurses' skills to patient needs to improve. Classification of costs. Costs are commonly classified as fixed or variable. Fixed costs are costs that will remain the same for the budget period regardless of the activity level of the organization, such as rental payments and insurance premiums. Variable costs depend on and change in the direction proportion to patient volume and patient acuity, such as patient care supply expenses. If more patients are admitted to the nursing unit, more supplies are used, causing higher supply expenses. Expenditures may also be Expenditures may also be direct or indirect. Direct costs are expenses that directly affect patient care. For example, salaries for nursing personnel who provide hands-on patient care considered direct costs. Indirect costs are expenditures that are necessary but don't affect patient care directly. Salaries for security or maintenance personnel, for example, are classified as indirect costs. Determining the salary personnel budget. The salary budget, also known as the personnel budget, projects the salary costs that will be paid and charged to the cost center in the budget period. Managing the salary budget is directly related to the manager's ability to supervise and lead the staff. Better managers tend to have more stable staff with fewer resources spent on supplementary staff, turnover, or absenteeism. In addition to anticipated salary expenses, factors such as benefits, shift differentials, overtime, on-call expenses, and bonuses and premiums may affect the salary budget as well. Benefits. After the number of required full-time equivalents, FTEs, is determined, it is also necessary to determine how many FTEs are necessary to replace personnel for benefit time, vacations, holidays, personal days, etc. This factor can be calculated by determining the average number of vacation days, paid holidays, personal days, bereavement days, or other days off with pay that the organization provide, and the average number of sick days per employee as experienced by the cost center. Shift differentials. Some facility use a set percentage to determine shift differential. 10% for evenings, 15% for nights, and 20% for weekends and holidays. For example, if the hourly rate is $18 for instance, then the cost for a nurse working evenings would be $18 plus $1.80 for each hour worked. On an 8-hour shift, the total cost would be $158.40. And for the year, $41,184. Other facilities use a set dollar amount per hour as the shift differential. For instance, evenings adds $2.50 per hour to base pay, night shift $4, and weekends $2.50 additional pay. Overtime. fluctuations in workload, patient volume, variability in the admission patterns, and temporary replacement of staff due to illness or time off all create overtime in the nursing unit. A projection of overtime for the next year can be calculated by determining by staff classification, RN, LPN, nursing assistant, and other employee classifications, the historical or typical number of hours of overtime worked, and multiplying that number by 1.5 times the hourly rate. For example, if the average number of overtime hours paid in an RN in a unit for RNs is 35 an hour, hours per 2-week pay period, the average hourly rate is $18. The projected overtime cost for the year would be $24,507 for the RN category. On-call hours. If the nursing unit uses a paid on-call system, the appropriate number of hours that employees are put on call for the year should be estimated and the cost added to the budget. Typically, under the on-call system, staff members are required to be available to be called back to work if the patient need arises, and the number of hours on call are paid at a flat rate per hour. Premiums. Some organizations offer premiums for certifications or clinical ladder steps. In this situation, a fixed dollar amount may be added to the base hourly rate of eligible personnel. For example, an additional $1 per hour paid for professional certifications. This would result in the hourly rate of the employee being adjusted from a base of $18 to $19. In this case, if the employee is full-time and works 2,080 hours a year, 40 hours a week, multiplied by 52 weeks a year, the annual new salary would be $39,520 or $19 multiplied by 2,080. Salary increases. Merit increases and cost of living raises also need to be factored into the budget projections. These increases are usually calculated on base pay. For example, if a 3% cost of living raise is projected and the base salary for an RN is $40,000, then a new base rate becomes $41,200. Additional considerations. Other important factors to consider when developing the salary budget are changes in the technology, clinical supports, delivery systems, clinical programs, or procedures and regulatory requirements. Changes in patient care technology or the introduction of new equipment may influence the number, skill, or time that the unit personnel may spend in becoming trained to use the new nurse equipment, and later operating and maintaining it. If significant, the projected number of additional labor hours for the new budgetary period should be incorporated into the request. The Joint Commission, the organization that accredits healthcare organizations, evaluates an institution to determine whether it is adhering to the level of staffing required to maintain a safe patient care environment, the Joint Commission of 2011. For example, the institution may have established a standard for critical care units and some other specialty units that a minimum of 2 staff members are required at all times, regardless of patient number or acuity. Additionally, some states have mandated staffing levels. Departments such as environmental services, dietary, escort, or laboratory may provide the nursing unit with support in performing certain tasks, such as transporting patients or specimens. Any change in the level of support they provide should be reviewed, and the effect of such change on the unit's staffing levels should be quantified for the next year's budget request. Changes in staffing can place new demands on the unit. Therefore, orientation and additional workloads needs should also be considered. In addition, changes might be made in the way the organization charges costs. For example, Some direct or indirect costs formerly charged under other divisions might not now be allocated to the various units. You might find your unit charged its fair share of the heating or security budget. Major changes, of course, are planned ahead of time, and some changes occur during the budget year, and the unit might be expected to absorb these additional changes within its original budget. Managing the supply and non-salary expense budget. The supply and non-salary expense budget identifies patient-related supplies needed to operate the nursing unit. In addition to supplies, other operating expenses such as office supplies, rental fees, maintenance costs, and equipment service contracts may also be paid out of the nursing unit's non-salary budget. An analysis of the current expense pattern and a determination of its applicability for the next budget period should be performed first. Pardon me. Any projective changes in patient volume, acuity, patient mix should also be considered because they will all affect next year's supply use and other non-salary expenses. As an example, if patient days for a particular type of patient are projected to multiply and cause a 5% increase in the use of IV solutions, this increase should be addressed in the budget request by requesting an additional 5% for IV solution supplies for the next year. Increases due to inflation rate index, or at a rate estimated by the finance or purchasing department are included as part of the budget request. A simple way of calculating the effect of a price increase is to take the estimated total ending expense for the year and multiply it by the inflationary factor. The capital budget. The capital budget is an important component of the plan to meet the organization's long-term goals. This budget identifies physical renovations, new construction, and new or replacement equipment planned with a specific time period. Organizations defined capital items based on certain conditions or criteria. Usually, capital items must have an expected performance of 1 year or more and exceed a certain dollar value, such as 500 or 1,000. The capital budget is limited to a specific amount, and decisions need to be made how best to allocate available funds. Priority is given to those items needed most. Not all items that fall under capital budget will necessarily get funding in the given year. Today, few nurse managers are asked to prepare a capital budget because most organizations are buying through consortiums or negotiated agreements with one supplier. Many healthcare organizations have departments that coordinate bringing in selected vendors and items and limited choices to that equipment. The nurse manager would then be responsible for reporting what needs exist, helping select and determine the amount of equipment needed. The capital pool is expensed out across all units that use the equipment. The impact of new equipment on the unit's expenses, such as the number of staff needed to run the equipment, use of supplies, and maintenance costs, need to be considered as part of the operating budget. However, likewise, the need for additional nursing and non-nursing personnel to operate the new equipment, additional workload, and training of personnel should be quantified for the next year's budget. Timeable for the budgeting process. Depending on the size and complexity of the organization, the budgeting process takes between 3 and 6 months. The process begins with the first level manager. The individual at this level of management may or may not have formalized budget responsibilities, but he or she is key to identifying needed resources for the upcoming budget period. The manager seeks information from staff about areas of needed improvement or change and reviews unit productivity and the need for updated technology or supplies. The manager uses this information to prepare the first draft of the budget proposal. Monitoring budgetary performance during the year. The difference between the amount that was budgeted for a specific revenue or cost and the actual revenue or cost that results during the course of activities is known as the variance. Variance might occur in the actual cost of delivering patient care for a certain expense line item in a specific period of time. Nurse managers are commonly asked to justify the reason for variances and present an actual plan to reduce or eliminate these variances. The reports show expense line items with the budgeted amount, actual expenditure, variance from budget, and the percentage from the budgeted amount that such a variance represents. These reports often also show the comparison between actual year-to-date results and the year-to-date budget. Variance analysis. In the daily course of events, it is unlikely that projected budget items will be completely on target in all situations. One of the manager's most important jobs is to manage the financial resources for the department and to be able to respond to variances in a timely fashion. When expenses occur that differ from the budgeted amounts, organizations usually have an established level at which variance needs to be investigated and explained or justified by the manager of the department. This level may be a certain dollar amount, such as $500, or it may be a percentage such as 5% or 10% increase above the budget. Salary variances with salary expenditures variances may occur in volume, efficiency, or rate. Typically, these factors are related and have an impact on each other. Non-salary expenditure variances. A non-salary expenditure variance may be due to the changes in patient volume, patient mix, supply quantities, or prices paid. New additional or more expensive supplies used at the nursing unit because of technology changes or new regulations could also influence expenditure totals. Position control. Another monitoring tool used by nurses is the position control. The position control is used to compare actual numbers of employees to the number of budgeted FTEs for the nursing unit. The position control is a list of approved, budgeted FTE positions for the nursing cost center. Here are 3 alternative solutions. Meet with the patient to discuss the plan and explain that with his initial clinical presentation, the physician's decision to place the PICC line was reasonable and the hospital will not waive charges. Agree to negotiate charge with the patient because the PICC line was placed with reasonable and prudent judgment, but was not utilized as long as they initially discussed with the patient. Agree to drop the charges for the PICC line placement. Patient is not able to obtain resources needed when discharged. A patient is ready for discharge to home but is on an expensive antibiotic. Even with insurance, she can't afford the copay of $200. So the healthcare team has to try and find a resource to help the patient pay for the antibiotic or find a replacement drug. Staff impact on the budget. Staff can accurately affect the organization's finances. Misuse of sick time, excessive overtime or turnover, and wasteful use of resources can result in negative variance. The manager plays a key role in explaining the unit's goals, the organization's financial goals, and how each individual is responsible for helping the organization meet those goals. Improving performance. Organizations have implemented a number of different programs and incentives for increasing employee awareness and minimizing costs. Techniques to decrease absenteeism and turnover may be instituted. See Chapter 20. Magnet hospital performance. In magnet certified hospitals, staff are taught about budgeting, how the unit's money works. Bedside staff make excellent informed decisions about what resources should be used and understand and they understand and take the budget management. Besides, staff are empowered to make decisions that impact how they work. That concludes lecture for week 4, NUR 491. Any questions, call, text, or email. Thank you very much.